Welcome to Trying to Conceive with Dr. Sasha Hakman, where we break down the science of fertility, share real patient stories, and explore the latest innovations in reproductive medicine. My name is Dr. Sasha Hakman, and I'm a double board certified OBGYN and reproductive endocrinologist and infertility specialist. I practice at HRC Fertility in Beverly Hills, but this podcast is an independent project created and hosted by me separate from my clinical work. Don't forget to subscribe so you never miss an episode. And if you want exclusive updates and resources, be sure to sign up for my newsletter. Just click the link in the episode description. Hey guys, welcome to TTC with Dr. Sasha Hakman. Today's episode is a solo episode, and the purpose of solo episodes here is for me to educate you about specific topics with the hope that you will walk away from this episode understanding a little bit more than you did before about that specific topic. And today's topic is about the basics of IVF. So you have made the commitment and made that decision to move forward with in vitro fertilization. And something that I see very often from friends, family friends, and in my DMs on Instagram all the time is the overwhelm that comes with trying to understand this process. It is not uncommon for patients to walk away from their consultation knowing that they have to do IVF, but not really understanding the process. Either it wasn't correctly or thoroughly explained to them, or alternatively, it was, but they were just so overwhelmed with the information that they walked away not really grasping much of it. So my hope is today you will walk away understanding a lot more about the basics of the process of IVF so that you can make better decisions when it comes to the specific sort of treatment modalities that you can do in a lab. All right, so when it comes to IVF, before getting into it and getting into all of the nitty-gritty of the steps, there are some fundamental things you have to understand first. So first, we're going to talk about sort of the anatomy of the ovary and then the hormones that are involved in a menstrual cycle. And for those who are watching who may understand this part, you might be rolling your eyes, but you would be surprised how many men and women are out there who actually have no clue how the menstrual cycle works. So let's begin with the anatomy of the ovary. The ovary obviously is the organ that contains your eggs, but where are they in the ovary? It's not like they're just free floating. The ovary is comprised of different cell types and tissue, and obviously your eggs are in your ovaries, but each egg is contained in something called a follicle. And now most of these follicles, basically this tiny little sac that presumably contains one egg inside of it, are in the resting stage, and these are known as primordial follicles. They are microscopic and they cannot be seen with the naked eye. However, as they leave that resting stage, which takes about an average of 3 months, they turn into what's known as antral follicles, which are larger sacs filled with fluid and that egg inside of it. Now, the egg inside of each follicle is surrounded by a crown of cells, and these cells are what are responsible for a lot of the hormone production and cell signaling to help grow and mature that egg. And the fluid that surrounds the egg helps to nourish it. This is why several months leading up to IVF, lifestyle, so nutrition, exercise, sleep, stress, supplementation, and then other forms of, negative lifestyle like smoking, tons of alcohol or excessive alcohol consumption can either positively or negatively impact the quality of that egg. And that's because it's in the follicular fluid, which the egg is directly exposed to. Now, these antral follicles are the ones that are able to be stimulated to grow and eventually release an egg. So that's just sort of the basic foundation of the anatomic portion of the ovary that you need to understand. Your eggs are in follicles. Your antral follicles are what are available to be stimulated. The follicle count that you have, so the antral follicle count you have in a given point in time, is indicative of your ovarian reserve, meaning how many eggs you have left. And like I mentioned before, there is that crown of cells surrounding the egg. They produce two very important hormones. The first one is anti-Müllerian hormone, AMH, which is another marker for your ovarian reserve, so how many eggs you have remaining. And then also estrogen. That is where so much of the estrogen in your body comes from, and that's why it's constantly fluctuating based on where you're at in your menstrual cycle. So now that we have that covered, let's go over some of the basics of the menstrual cycle, because that is the foundational knowledge you need to sort of understand what we're even doing with IVF. Keep in mind, I'm just trying to keep it basic as much as possible, and I will leave more details about specific add-ons and nuanced things that we can do to manipulate an IVF cycle outcome based on a specific diagnosis. This is just the basics here. So when it comes to the menstrual cycle hormones, cycle day 1 is the first day of a bleed, okay? This is where your hormones are all nice and low, or at least they should be. There are 4 main hormones that you really want to keep in mind when it comes to the menstrual cycle. 2 are coming from the brain, known as FSH and LH. FSH is known as follicle stimulating hormone. It does exactly what the name implies. It's a hormone that stimulates the follicles to grow. And luteinizing hormone, or LH, that is the hormone that is responsible for ovulation, the release of an egg. The other 2 hormones are produced by the ovaries, specifically the cells within the follicle. The first is estrogen, and that rises as an egg grows and gets ready for ovulation, and then progesterone, which starts being produced and secreted after ovulation in preparation for a pregnancy, hence why it's called progesterone. Progestation, and gestation means pregnancy, so it's pro-pregnancy hormone. In the beginning of the menstrual cycle, all of your hormones are quiet. You did not conceive. And your brain knows this. So what does it want to do? It starts releasing the signal of FSH. Now, let's say that, for example, you have 15 antral follicles in the beginning of your menstrual cycle. That is your personal ovarian reserve. Now, this number varies tremendously from woman to woman. We also know that it decreases as we age. That's just our physiology and how we're designed. But in the beginning of the menstrual cycle, as the brain secretes FSH, it only secretes enough for these follicles to really compete with one another. And as one follicle dominates and grows, and the cells in that follicle are producing estrogen, the estrogen sends a signal back to the brain to let it know, I got this, I'm winning and I'm growing. And so the brain slows down the release of FSH until it completely stops it as that follicle continues to grow. What happens to the other follicles that were there? They undergo a form of programmed cell death known as atresia in the ovaries. So these follicles essentially die and disappear forever. The only way to rescue these follicles is the hormone FSH. It's basically food for the follicles. So in a natural menstrual cycle, there's only enough FSH to recruit one dominant follicle typically. And then once the estrogen peaks, it then provides a signal to the brain. We don't fully understand what that stimulus is, but somehow the brain decides it's time to release that egg, and you get an LH surge. The hormone LH only surges for about a day or so, and it's the day after, once it's coming back down, that you release the egg. So something really important to know about LH, it's not only responsible for the act of ovulating and releasing that egg, so rupturing the follicle, having the egg get released, that follicle reseals and starts making progesterone, and that follicle is known as the corpus luteum, hence why it's called the luteal phase, and hence why it's called luteinizing hormone. Now, LH is also responsible for maturing the egg, meaning it undergoes meiotic division to split the chromosomes so that you only have half of the genetic material, and that way the egg can be fertilized and accept more genetic material from sperm. So a very, very important thing to keep in mind, which will make more sense about the medication protocol for IVF. So that's just the foundation you need to understand how we do and why we do what we do when it comes to in vitro fertilization. So now let's talk about the steps. Step 1, priming. Now this is optional. Some doctors do not like to prime. Other doctors love to prime, and they do it with everybody. Someone like myself, I actually just like to select based on the candidate. Some patients are better off with priming. Some are better off without. It just really depends on the specific clinical context. Now, with priming, what that means is that in the menstrual cycle, prior to your period, we either give you birth control pills, or you might get an estrogen-only pill for maybe about a week, sometimes more. Alternatively, we can prime with testosterone, either in the form of a cream or a pill. There's different ways to administer it. And then some physicians will do, depending once again on your case, pre-treatment with something like growth hormone or Omnitrope. Now, priming is just in preparation for the cycle. There's a few reasons why people will do it, either to, the intention is either to prevent the formation of cysts. It could be to manipulate your cycle start in order to schedule your IVF cycle according to what your travel needs are. If you have a particularly busy travel schedule, estrogen has been shown to help to sort of synchronize the follicles more. And the goal of synchronizing the growth of these follicles is that they're ready at the same time and you maximize the number of eggs that you might retrieve. And then testosterone priming is a little bit controversial, but there is some pretty good data to suggest that with a testosterone prime, you may improve pregnancy outcomes or the pregnancy rate for women who have diminished ovarian reserve. So your egg reserve is lower than average or lower than normal. So now, if you are not priming and you are just waiting for the onset of your period to get started with IVF, that is known as a straight start. All right, so now that brings us to step 2, ovarian stimulation. Ovarian stimulation is the process of recruiting your follicles. So whether you are doing egg freezing or IVF, it's the same thing. We are stimulating the ovaries to grow those follicles and recruit as many eggs as we can. Now, this is where your medication protocol, your medication dose will highly vary depending on your age, depending on your ovarian reserve, so how many follicles are there, and depending on if you've already done an IVF cycle, how things looked in the prior cycles. Now, if you've already done an IVF cycle and you're listening to this, I'm really hoping that this all just sounds redundant to you. But if not, it's really great that you are trying to understand more about how this works so you can make better decisions about future cycles. So when we go ahead and get started on the cycle, in order to determine if it is a good time to start, we always do something called a baseline. And this is a baseline ultrasound with blood work. In this ultrasound, we are looking at the ovaries to ensure that you don't have any cysts or any weird activity going on that might interfere with the hormone stimulation, resulting in a poor response to medication and just not a good outcome. If hormone levels are low, unless you're already on hormones and they're going to be high, and the ovaries are nice and quiet, then usually you get the thumbs up, the green light to get started on your injectable medications. Now, there's so many different protocols, and I'm going to leave that for a separate episode, but the gist of the medications for IVF is primarily you are getting follicle stimulating hormone, the hormone that the brain is naturally producing to get a follicle to grow. But now we're giving it at much higher doses in an injectable form, okay? And you have to take it every day because it's got a short half-life. It doesn't stay in the body for a very long time. So anytime you're hearing people talk about the meds staying in their system for such a long time and it negatively affecting reproduction, that is not true. It is short-acting. It does not last in the body because if it did, you wouldn't have to take it every day. So FSH, you are taking that every day. There are two main forms of FSH. One is lab-made, what we call recombinant FSH. The trade names for that in the US are Gonal-F or Follistim. Those are the two commonly used ones. And then you have Menopur, which is a combination of FSH with a little bit of LH. And this is actually extracted from the urine of menopausal women, hence why it's called human menopausal gonadotropin, because menopausal women, since they don't have any estrogen naturally in the body, they secrete tons of FSH and LH in the urine because the brain is still just trying to stimulate the ovaries, even though there's nothing to stimulate. So those are the two primary hormones that are used in order to help grow those follicles. Additionally, you're going to need a medication to prevent premature ovulation, because if there is not that added medication, eventually at some point before your egg retrieval, your brain's going to think, oh my gosh, there's an egg that's ready for ovulation. Let's make a baby. And so it will naturally endogenously cause an LH surge, and then you will ovulate and we can't even retrieve those eggs. That is not an outcome we want. So we have to add a medication that will prevent that premature ovulation. And there's different mechanisms behind these medications, but it is the medication that is used to prevent premature ovulation that will determine the type of medication protocol that you are taking. Now, during this time, stimulation is an average of, 8 to 12 days. Sometimes it's more than that, just depending on your individual response. And during that time, you're going into the clinic every few days for monitoring. The monitoring is ultrasound and blood work to track your hormone levels in response to the growing follicles. This is to help determine when you have to potentially add a medication to prevent ovulation. It also helps to track your response to FSH to see, do you need to up the dose or lower the dose? And then finally, to determine when these follicles are actually ready. So once they reach a certain size, an average of around 20 millimeters, plus minus 5 millimeters, then they are ready for trigger. It is suggestive that there should be a mature egg in there, but we also track your estrogen levels to correlate it clinically. And once your follicles are ready, you get the trigger shot. What is the trigger shot? The trigger shot is mimicking an LH surge, and it is perfectly timed with your egg retrieval so that the LH surge gives the eggs enough time to mature. And then it's also before the egg retrieval, so you don't ovulate before then and we miss the mark. The average time that most clinics will use is 36 hours. Some physicians will use 34, 35 hours. Others I've heard use 37. It's all kind of right. There's no particularly wrong answer when it comes to that. It's just different standard practices in different clinics. So now you've triggered, and 36 hours later is the time for step 3, the egg retrieval. So the egg retrieval is typically done under anesthesia. So you won't feel it, you won't remember it, which is great. It is a minimally invasive procedure where we take a needle. It's a pretty small bevel, so the width of the needle is small. It is long, but not all of it is going into your body. It is attached to a vaginal ultrasound probe, which the needle is then introduced through the wall of the vagina, because behind the wall of the vagina is where the ovaries sit. So going through the wall of the vagina, you go into the follicles, and those follicles, when they're that big, they're full of fluid, and a mature egg should be floating around in that follicular fluid. If it is not, and it's really difficult to acquire these eggs, that usually does not bode well for that egg. It is unlikely to be mature or unlikely to fertilize and lead to a healthy embryo. So you go in the needle and you suction all the fluid, and it's all connected to tubing, which once the fluid lands in that test tube, it is handed to the embryologist. So the operating room is attached to the embryology lab, where the embryologist is there picking up the tubes, and they pour that fluid in a tiny circular dish where they're looking under the microscope and they're counting your eggs out loud. Now, at the same time, if you have a male partner whose sperm you are using, then your partner is giving us a fresh sperm sample. Sometimes we use frozen, either because they're out of town or because they have difficulty performing under pressure. But we need to have sperm available if we're doing IVF, because once again, this stands for in vitro fertilization, meaning we're fertilizing the eggs in a lab. So for those who are freezing their eggs, they are doing the exact same thing up until the point of retrieval. And at that point, the eggs that are mature are frozen and saved for later. For those who are doing IVF, we need sperm. At that time, the sperm is washed and cleaned. And now this is where there are differences in lab in what comes next if we're talking about a standard IVF cycle. Now, there are two types of fertilization. The first is conventional. You take the sperm, you take the eggs, and you put them in a dish together. And the next day, you check under the microscope to see which one's fertilized. Alternatively, if you are planning to do something called ICSI, ICSI, which stands for intracytoplasmic sperm injection, then what we have to do, step one, once we acquire the eggs in the lab, remember I said there's a crown of cells surrounding these eggs. We have to shave the cells off of the eggs, and then we inject the sperm directly into the egg. So we look under the microscope for the best looking sperm, and then we have to immobilize it. Typically, it's by knocking its tail or breaking its tail. It gets suctioned into a micropipette and then very gently handled by injecting it into the cytoplasm of the egg. Now, whether you should be doing conventional or ICSI is a loaded conversation. However, the indications for absolutely doing ICSI is if there's severe male factor infertility, you're using previously frozen eggs because the shell of the egg is really hard and difficult for the sperm to penetrate, or if you had previous fertilization failure in your last IVF cycle. That being said, a lot of major labs, including our own, do ICSI as sort of the standard because in about, depending on the study that you quote, 5 to 15% of cases end up with total fertilization failure, which is defined as less than 30% of the eggs get fertilized. The average fertilization rate is about 70%. So we do not expect all the eggs to get fertilized, but I expect to see at least 70% fertilized. Sometimes it's a little bit lower because once again, it's an average. And the thing about averages, some people do better and some people do worse. But if you have very poor fertilization, that's a very devastating diagnosis. And for many, they only have the financial means to do one IVF cycle. So in a lot of cases, it has increasingly grown in popularity that throughout the country, most of us are just doing ICSI on everyone because nobody wants that chance of total fertilization failure or very poor fertilization and having to do another IVF cycle. That being said, if you feel strongly about conventional IVF, it is not inappropriate if sperm looks good and you're using fresh eggs, even if you are of advanced maternal age, because the studies have not shown that that increases pregnancy rates. So it is not an inappropriate selection if it's more a la carte in your clinic and you're paying additional fees for things like ICSI. Alternatively, if you do conventional IVF and they look the next day and there's very poor fertilization, you could do something called rescue ICSI, where you then take the sperm and inject it directly into the egg to see if you increase the number of eggs that can get fertilized. Once fertilization occurs in the lab, then we culture these developing embryos. So most labs nowadays have what we call benchtop incubators. So they're small incubators. If anyone has any science background, did any research in a lab, even in undergrad, when you go in a lab and you use an incubator, they historically are huge, almost like the size of a fridge. But for embryos, we now use these tiny little benchtop incubators, and they mimic the environment of the fallopian tube the first few days until it, sort of mimics as it enters the uterine cavity. We culture for anywhere from 5 to 7 days after the egg retrieval. A lot of labs are increasingly culturing to day 7. Historically, they would only culture between day 3 and 5, but with improving technology and more data, we are now seeing that there are embryos, albeit less, but there are embryos that, it takes them all the way to day 7 to become what's called a blastocyst. They have a lower pregnancy rate, but it can still lead to a pregnancy. So we always try every effort to maximize the number of embryos that you will end up with. So the culturing process is typically you waiting a week after your egg retrieval to find out how many blastocysts you have. So after the egg retrieval, the day after, you should obtain your fertilization report. So understanding how many eggs were mature, how many were fertilized, and then 1 week later, finding out how many turned into an embryo called a blastocyst. So a blastocyst is an early embryo that has cells on the outside. That's called the trophectoderm, and those will become the placenta. And then there's the inner cell mass, which will eventually become the baby. Once it has reached that stage, the embryologist will grade them. And the grades, there's different grading systems, but the most common one involves getting a number score followed by 2 letters. And the number is indicative of the size of the embryo. So a 2 is an early blastocyst, 2 to 3 is very early blastocyst, 4 is an expanded blastocyst, 5, it started hatching, and then 6, it's already hatched. Okay, because there is a shell around the egg, and even as it develops into an embryo, around day 5 to 6, the embryo has to hatch out of that shell for implantation in the uterus to occur. So that brings me to, once you have that report of how many embryos you have, the options are either to not genetically test the embryos or to biopsy and do pre-implantation genetic testing. And we're really going to get into that a little bit today, so you understand the purpose of PGT, pre-implantation genetic testing. But if you're choosing not to test, option 1 is to do a fresh transfer. And there are some people who may be good candidates for a fresh transfer, but if you have high ovarian reserve, you are not a good candidate for a fresh transfer. And that's primarily because of one of the complications that may occur with IVF called ovarian hyperstimulation syndrome. But if your ovarian reserve is lower and you're really trying to get pregnant ASAP and you want a fresh transfer, that can be an appropriate treatment modality for you. Alternatively, you may still choose not to test, but then you freeze all the embryos, and this is particularly important for anyone who has high ovarian reserve or had an exaggerated response to the medications, because trust me when I say, if you had a hyper response to the medications and you do a fresh transfer, that pregnancy will be very, very miserable. And it is also less likely to be successful. So your best bet is to freeze all the embryos, wait until the hormonal environment goes back to normal. You have a period, hormone levels are normal, and now you get started to prep for the transfer. Alternatively, you can choose to do chromosomal testing of these embryos. Once again, that's pre-implantation genetic testing, or PGT for short. There's different types of PGT, the most common being PGT-A. A stands for aneuploidy. Aneuploidy means chromosomal abnormality. So that is what we are checking for, is chromosomal abnormalities. In order for us to do PGT, what has to happen is we need to do assisted hatching first. So I mentioned that there's a shell in the egg or surrounding the egg. And as the cells divide after it's fertilized and it becomes a blastocyst, that shell called the zona pellucida is still there. And assisted hatching means there's different techniques of doing this, but you're essentially opening up a little hole in that shell in order to get in and biopsy a handful of cells from the outer portion of the embryo. Remember, called the trophectoderm, which will eventually become the placenta. We typically only biopsy about 5 to 10 cells and then send that out for chromosome testing. Okay. And once you get a report, usually it takes about a week to get that report back. It'll tell you which embryos are presumably chromosomally normal versus chromosomally abnormal. And this often gets misconstrued as which embryo is viable versus non-viable, or which embryo is healthy versus unhealthy. And while we sometimes do say that to simplify things, it's not exactly what it means. Okay. When we do PGT and something comes back as euploid, what that means is it should be prioritized for transfer compared to the aneuploids. The ones that come back chromosomally abnormal are usually chromosomally abnormal, though there is some debate to say, if you're only biopsying about 5 to 10 cells of an entire embryo, it's not telling you what all the other cells are doing. And we now know that early embryos have some cells that are chromosomally normal and some that are abnormal. So depending on the location of biopsy, it might give you a totally different result. So PGT is very helpful to help us prioritize which embryo to transfer first to minimize time to baby. That is the purpose. It is to reduce time to baby. If you are not doing PGT testing, then we're sort of just guessing which embryo to pick first for transfer if you have multiple. Generally speaking, because they've already been graded, and so let's backtrack and go back to describing what the embryo grades look like. If it's a number score followed by the letter scores, the letters you want ideally are A, which is excellent, B is good, and C is poor. But embryo grading doesn't always mean everything. I've seen the lowest graded embryos lead to healthy babies, and I've seen the highest graded embryos just not be successful. Once again, these are tools to help us reduce time to baby in order to decide and prioritize which embryo to transfer back into the uterus first, because ideally we are only transferring one embryo at a time. Of course, there are exceptions to this, but generally speaking, we transfer one embryo at a time. So that is sort of the whole IVF process. A lot of people think that this includes the embryo transfer, but nowadays with how we're doing IVF, the embryo transfer is usually a whole separate cycle. And you may have multiple embryo transfers from one IVF cycle. It just depends on how many embryos were created. Advantages of doing pre-implantation genetic testing, once again, it's shortened time to baby. It helps us to prioritize which embryos are more likely to be successful. However, it's not the be all end all. And if you are not testing the embryos, it might just take a little bit longer because we don't have that information. So now I want to go through some expectations when it comes to IVF success, because there are a lot of myths surrounding doing IVF, which is that, it typically works the first time. It can help overcome the age factor. It can help overcome whatever infertility issues you're experiencing. It's really important to know, though, even infertile couples who do IVF electively for various reasons like gender selection or for genetic purposes to test the embryos for a specific disease, the stats for what we expect from an IVF cycle are as follows. So when we go to retrieve the eggs, there's usually about a 25% drop off from the follicles growing to how many eggs are actually usable and mature. From there, the average fertilization rate, which I previously mentioned, is 70%. But of the fertilized eggs, only about half of them will make it to blastocyst. So you keep getting these huge drop-offs. And then if you go to do pre-implantation genetic testing, or PGTA, depending on your age is how we expect how many will come back chromosomally normal or abnormal. So for instance, if you're under the age of 35, we expect about 60% to be chromosomally normal. If you're 35 to 37, it's about a 50% euploid rate. Okay, so that's still very good. I know that sounds terrible, but it's actually pretty good. That's when it's sort of at its best, when you're under 35. And so if I give a specific number example, let's just say you had 15 follicles that were there at your baseline. You start the medications and 12 follicles responded, and we were actually able to retrieve 12 eggs, and 11 were mature. So that's not an uncommon situation where not all the follicles responded to the medication. And then when you go to retrieve the eggs, not all of the eggs are mature. Now let's say, let's keep the math easy and say that 10 were mature at the time of retrieval out of those 15 follicles that were there. 7 out of 10 fertilized. Of the 7, let's be optimistic and say that this patient's under 35. And so since you can't have 3.5 embryos, you have 4 blastocysts. Not bad, 4 embryos. That does not mean 4 kids. Now, if you go to do PGTA and you're, say, 35, I expect 2 of those embryos out of the 4 to be chromosomally normal, or at least tested normal. But with each chromosomally normal embryo, that yields about a 65% chance at a baby. We're not even close to 100 here. We're talking 65%. And so why is that? Well, because there are various factors here, but we know that even when embryos are tested normal, it doesn't mean that everything is okay with that embryo. We are just biopsying a few cells here. There's also small duplications or deletions in the genes that can involve just a few hundred genes or even a few thousand genes that are not compatible with life. And that will not be detected in PGTA. So we don't even know that that's there. And we go to transfer it and it's unsuccessful. So if we see that this is happening over and over again, there is a very quick assumption that the uterus is the issue, but oftentimes it still may just be an embryo quality issue that we're just not detecting with PGTA as well. So now you have the embryos, and in a perfect world, you would have enough embryos for future siblings so that you're not going through ovarian stimulation again. However, if you don't have enough embryos for subsequent children, and you are more advanced in age and you know you're going to want multiple kids, it's not a bad idea to consider batching cycles and creating more embryos before you even get to transfer, particularly if you're in your late 30s, early 40s, and you want multiple kids. It's always a good idea to bank embryos for the future because let's say you're ready for baby number 2 at 41, 42. I promise you it's going to be harder than if you're 37 years old doing IVF. And I understand firsthand that desperate need to be pregnant yesterday. But it's sometimes better to just postpone things by a few months, put in that front work, get those embryos, and then get started on the embryo transfer process. Which brings us to that final step to getting pregnant, which is the FET, the frozen embryo transfer. So if you're not doing a fresh cycle with a transfer, now if you are doing a fresh transfer, this typically occurs 3 to 5 days after the egg retrieval, and you would be getting very specific instructions on starting progesterone immediately after the egg retrieval. But if you're doing a frozen embryo transfer, this is where we are now preparing the uterine lining. We kind of care what the ovaries are doing based on how it's going to interfere with the preparation of the lining. But the main focus here now is the uterus. So you have the embryo, it's cryopreserved, it's in liquid nitrogen. And now at the onset of a new period, you're getting ready at some point in time for the transfer. This involves increasing estrogen levels, similar to ovarian stimulation. In this case, not to acquire eggs, but rather the estrogen helps to thicken your endometrial lining. The endometrium is the cavity of the uterus where implantation occurs. So estrogen helps to thicken the lining. And once that lining is what we call trilaminar, it's basically this triple line pattern that we see on ultrasound. And if you've never seen it, be sure to let your office show it to you on ultrasound so you know what it looks like. But that trilaminar pattern, particularly around 7 to 12 millimeters, is what we're hoping to achieve. The trilaminar pattern is what we're hoping to achieve on ultrasound at a thickness of 7 to 12 millimeters. Sometimes you'll be thicker, sometimes you'll be a little bit thinner, but if that pattern looks beautiful and perfect, then that's typically okay. And at that point, this is where we start some form of progesterone exposure, and there's different ways to doing this. There are two main protocols to preparing the endometrium for transfer. The first is the more traditional route, which is a programmed FET protocol. The programmed protocol means that you're going to get estrogen in some form. So either patches, pills, or an injection of estrogen. And as your estrogen is rising, your lining thickens. And once your lining is ready, then you start progesterone supplementation. And the progesterone is typically progesterone in oil. So it's an intramuscular injection in the glutes. I did this for my first transfer. They are not fun. They are painful. The only thing that kept me going was knowing that it was for my baby. And I would do it over and over again, but it is certainly physically a harder protocol, but sometimes necessary for particular patients. The alternative is doing a modified natural FET or just completely natural, which is where either you're getting a pill like letrozole to help recruit follicles, or we're just letting you naturally recruit a follicle in a natural menstrual cycle. We track the follicle and the lining growth. And as that follicle gets ready for ovulation and the lining looks ready, this is where we typically give you a trigger shot similar to before the egg retrieval. But in this case, we do want you to ovulate. The ovulation will result in that follicle that released the egg becoming the corpus luteum. And that is what is responsible for your endogenous progesterone production to support a pregnancy. Now, in this particular protocol, some doctors may not supplement progesterone and others will supplement through suppositories, not necessarily injections. And usually the embryo transfer will be 6 to 7 days after that trigger shot and once ovulation has been confirmed. Sometimes they will bring you back after the trigger shot for hormone testing to make sure your progesterone levels are optimal and in leading up to the embryo transfer. And once it is your embryo transfer day, this is where a catheter that contains your embryo is gently placed through the cervix into the uterus under ultrasound guidance. And this is not under anesthesia typically, and it should not hurt. You should not feel cramping with this. You should not feel pain, and you should not have bleeding after this. Once the embryo is deposited in the uterus, you pull out the catheter, and the embryologist will then check under the microscope to ensure that it was deployed. So that is IVF in a nutshell. There are so many more things that we can do in order to try to optimize an IVF cycle depending on a particular patient situation. But this is sort of the foundation that you need to know when going into an IVF cycle to actually understand what it is that you're doing. I mean, you're injecting yourself every day. You're going in for multiple appointments. And if you are the partner, then you should also understand this process and be equally part of it, because oftentimes it turns into this physical, mental load on the woman, and that becomes very isolating when you're doing IVF. So always make sure, ladies, that you're involving your partners, even if they're not physically doing anything. They should know what's going on. They should understand the process and just be equally as involved, even if they can't take the shots. But also they can take sympathy shots too. If you have any questions about the process of in vitro fertilization, be sure to drop your questions.